Per day or per diem reimbursement methods are those methods in which some insurers reimburse the institutional providers, such as hospitals or nursing homes, etc., on a per day or per diem basis. The provider is paid a fixed amount for each day that the service is provided. Sometimes these rates are stratified, which means different rates are applied to different services. So, for example, a hospital might be paid one rate for a day in which a patient receives surgery or has a high level of medical intervention, and then have a lower rate for a day where they don't have such intensive treatment. So these stratified per diem days recognize that providers have different daily costs and are providing different types of inpatient care. An example, might be in an obstetrics ward. So the day that the baby is born requires a higher level of intensive treatment than the next day or the day after, where the care for the mother in particular is going to be reduced. Global reimbursement is the reimbursement in which the payer pays a single prospective payment that covers all of the services delivered in a single episode, whether the services are rendered by a single provider or multiple providers. So, again, using that example of obstetric services related to a pregnancy, all of the prenatal and postnatal visits, including the delivery, et cetera, would all be included in the general cost. So it wouldn't be separated out. So also another example would be someone having heart surgery. You could imagine how there would be multiple providers providing services, but they would all be bundled together under the reimbursement system. So the facility or the institution would get a set fee or set reimbursement for all of the services that are provided. We talked a little bit about capitation before. This is completely different than reimbursement. Under this capitated reimbursement, the provider is paid a fixed amount per covered period. So usually it's a month, but it could be more than that. And that amount is paid regardless of the amount of services provided. So, for example, a physician might be paid $15 per member per month for handling, say, 100 patients under a managed care plan. So that capitation payment, as we talked about before, is under managed care organizations, and generally it's used to reimburse primary care physicians. And we've talked a little bit about how that can change the face of reimbursement and how it can change the level of care that you might receive. Now, we've talked a lot about reimbursement. There's something that's kind of a little bit newer, and it's called pay for performance systems. And this has gained popularity recently, particularly with the Affordable Care Act and the focus more on quality measures of healthcare. So, under pay for performance systems, insurers pay providers with a little bit of extra if certain standards are met. So, what they're looking for is for example, a primary care physician or practice may receive additional reimbursement if goals are met. For example, they have 85% of their female patients get mammograms to screen as a preventative measure for future treatments down the line. Or maybe 90% of diabetic patients are having quarterly blood tests, something like that. So it's a way to ensure that quality standards are being met. It can also apply to things like medical errors. So a hospital might get a little bit of an extra incentive for having no medical errors or having no infections that are as a direct result of the hospital practices. So the idea is that you're creating incentives for better quality care which is more expensive in the short term, but the goal is really looking at the long term. So if we can prevent some of these long-term diagnoses and conditions and challenges, then the money is well spent in the short term, and to create better quality care. So we're going to talk for a minute about some provider incentives, because providers have both their incentives that we've talked a little bit about, and then there are also risks. There are different methods of reimbursement create these different incentives and risks for the provider. The first one we're going to look at, or in general category we're going to look at, is provider incentives. So these providers, like any other person in any other business, react to the incentives that are created by this financial environment. So they want to receive these incentives. Who doesn't? These alternative methods can have a significant impact on the provider behavior. So first, looking at the cost-based reimbursement, that's kind of like giving the provider a blank check to acquire facilities and equipment and incur operating costs, because the payers are reimbursing the providers for service-related costs. So the incentive for them is to incur these costs. If they're going to get paid for it, why not spend the money? So if you're going to get the money back, why not spend the money? So facilities will upgrade services, etc. What can happen is that services that are not required are provided because these additional services lead to higher costs. These higher costs lead to higher revenues. So that's one of the incentives for the provider. Under charge-based reimbursement, the providers have the incentive to set higher prices and offer more services. Reimbursement is based on charges. We talked about the fee-for-service reimbursement. The strong incentive exists to provide the highest possible amount of services. If providers can increase utilization, that increases their revenue. So why wouldn't they do it? They're creating more visits, they're ordering more tests, they're extending patient stays, and so on. So these charge-based reimbursement systems, they, to some degree, encourage providers to contain cost, but the incentive is weak because the charges are more easily increased than costs can be decreased. So this is one that's, also provides an incentive for the provider. Under per day also can increase, there's an incentive to increase the length of stay. So, generally a person stays in a hospital for X number of days. Maybe we'll have to extend it for one day, or maybe we have you come in the night before a procedure. This is one that's being much more closely monitored, and insurance companies, and particularly Medicare and Medicaid, there are set day limits for specific diagnoses. So this is one that is not as much of an incentive anymore, because with these treatment guidelines, there's generally a guide as to how many days you can spend in a hospital for a particular diagnosis or particular procedure. Also, under the perspective, where am I? Sorry, guys, lost my place. Under global reimbursement, there is this issue of bundling and unbundling. So the incentive, well, let me explain first. Bundling and unbundling. Bundling means that they are charged or reimbursed a set amount for all of the services. So we talked about that. Unbundling is the person is billed, or the insurance company is billed for each individual service. So there's different ways that hospitals or facilities manage that. Obviously, you can think of it like your cable. I think this is the best example I can give you. So cable companies often bundle your phone service and your cable, your internet, all of that together. and they give you a better deal on those services, but you pay just one monthly fee for all of those services. And the same thing is true of healthcare services. So they'll bundle the services. So you go in for a particular surgery. Again, I'll go back to my knee replacement. So obviously I had a surgeon, but I also had nurses, and I had a stay, and I had PT, and I had OT, and lots of services. In some places, they'll bundle that as a whole package deal called knee replacement, and will be reimbursed at a set amount. Now, as you can imagine, if I had a bill for PT, and I had a bill for OT, and I had a bill for the surgeon, and I had a bill for the time in the operating room and in the rehab setting, etc., that without that bundling, it would probably be much more expensive. So again, the incentive is to unbundle and to be able to bill for all of the different things that you received. The issue that often comes up with that, and insurance companies have an issue with, is the duplication of services. So it's all a matter of how those particular services that you receive are coded, which we'll talk about in a little bit. Providers also are subject to some risks, just like incentives. So cost and charge-based reimbursements, these are the least risky for the provider, because the payer more or less ensures that the provider's costs are covered and that they're going to earn profit. So there's not a whole lot of risk involved in those. In all of the reimbursement methods except cost-based, providers bear the cost of service risk in the sense that the cost can exceed the revenue. A primary difference is the ability of the provider to influence the revenue-cost relationship. So what I mean by that is that if the providers set charge rates for each type of service provided, they can most easily ensure that the revenue exceeds the cost, okay? So they're setting a fee for particular services and billing the insurance company, but that billing amount is more than it actually costs them. So in that type of situation, not a lot of risk for the provider. Prospective payment creates a little bit more of the risk for the provider. So in this case, the payers are setting the reimbursement rates on the basis of what they believe to be sufficient. If the payments are set too low, the providers can't make money on the services without sacrificing quality. So that can happen. That's the one where the hospital or the insurance company says, for this diagnosis, you're going to get paid this amount, period. And then that's either what the provider has to bill for, or sometimes that difference is then passed down to the patient, which is a whole nother issue. Under capitation, there is some risk as well. Providers assume what they call utilization risk under capitation, as well as some of the ones under what we've already talked about. But the assumption of this utilization risk has traditionally been on the insurance company rather than the provider. But in fee-for-service, the financial risk of providing healthcare services is shared between the providers and insurers. Because if the costs are too high, the providers suffer. If too many services are consumed, the insurers suffer. So really, when it comes to risk, it's equal risk for both the provider and the payer. Because remember, this is when they set a set amount per person, regardless of the level of services that are utilized. So if a lot of services are utilized, then the insurance company has the risk. I'm sorry, the provider has the risk. If there are not many services utilized, then that is the risk for the payer, because they have not received, or they've paid out for those people, but they haven't actually used the services.